My Lords, I'm going to structure this speech untraditionally, beginning with a short list of some of the issues that I expect to pick up in committee, adding to the list already laid out as her agenda by my noble friend Baroness Jones of Moulsecoomb. The British Association of Social Workers is concerned about the dilution of local authority responsibilities. The Institute of Alcohol Studies points out the failure to address the harm done by advertising for alcoholic products. The Venice Commission concludes that it undermines trust in the Parliamentary and Health Service Ombudsman. Unpaid carers are deeply concerned about Clause 80, as the noble Baroness Lady Pitt-Keithley outlined. And of course, multiple organisations and peers are gravely concerned about the lack of workforce planning. But I want to take most of my time looking at the big structural changes introduced by this bill. Astonishingly, as many noble lords have noted, at a time of tremendous pressure and struggle for our health service. The warning from the British Medical Association that the bill, quote, will do more harm than good in this context must be noted. Now, I want to engage particularly with two speeches, starting with the noble Lord, Lord Lansley. He raised the way the kind of structures created by the bill reflect those, quote, JP Morgan and Rockefeller used when creating vast monopolies, close quote. Those lords insisting vigorously, very vigorously, among them the noble Lord, Lord Stevens of Birmingham, that this bill is not about privatisation, really it is not, might like to reflect on that analogy. The noble Lord, Lord Lansley noted that integrated care systems have been around in one form or another for 6 years already, as noted also by the noble Lord Abouale. They were brought in de facto into the NHS without parliamentary oversight, and now we're being asked to approve that model. Somehow that makes me think of the Henry VIII powers that, rightly, so exercise many of the legal experts in your Lordship's House. Now, the idea of integration, I don't believe there's anyone who disagrees with that. Regarding each individual engaged with the system as a person needing a mixture of medical and other care, not as a set of conditions, is obviously essential and all too rare. But the big question is how. And there's an important question to ask about models, the origins of them. And the origins of so much thinking about healthcare systems in the UK come from the United States, as do many of the personnel from giant American healthcare companies. I'm talking, of course, about here at the top of management. That's astonishing when you think that the world's richest country, which can reasonably be classed as having the world's worst health system. It's a system that absorbs enormous resources, financial, physical and human, to produce astonishingly bad outcomes, whether measured by mortality, morbidity, the actual volume of care provided, or inequality. Yet we seem to draw most of our thinking and many of our senior personnel from the US. But maybe I'm wrong that this is a failure. Maybe the issue is the purpose of the system. If you acknowledge that the purpose of the US healthcare system is to be a cash cow, not a care provider, then on that measure it's a raging success. A raging success that's already consuming about 8% of England's NHS spending and providing a quarter of our mental health inpatient beds. Although it hasn't always been so. Think back to 2015 and Hitchinbrook Hospital, briefly in the hands of healthcare company Circle. Soon, care was rated inadequate. The company complained that it wasn't making any money and handed it back to the government. So multinationals have found it hard to make money from operating some elements of our current health system. But now potentially they'll have a new way of taking over. The Integrated Care Board model is closely based on the Health Maintenance Organisation, also known as managed care organisations. These are responsible only for providing limited free services to an identified group of people. In the US, they're kind of like customers, but very constrained customers. But the sad reality of where we are now in the UK is that with our level of spending on health significantly below that of nations of comparable wealth, we're already heading towards this. Open Democracy has found that 1 in 5 people it surveyed had had a doctor or other health professional suggest that they needed to go private to get the care they needed. 9 out of 10 patient-facing staff said they'd been unable to give a patient treatment or a procedure they would benefit from. With a block of patients and a fixed budget, how much further might this bill take us down that road? Now, lest you think I'm going out on a limb here, I point out that the BMA has noted that the bill, quote, risks making it easier for private companies to win NHS contracts without proper scrutiny. And we've already seen this in action over decades under successive governments in our social care system. The bill does nothing to tackle the predatory financing that has consumed our care home sector, with 84% of beds provided by for-profit companies, with 1/6 of the fee for a bed in financialised homes going towards interest payments. So, my Lords, if this brief outline has left you wondering, puzzled about the apparent lack of resistance from the front bench on this side to the basic structural changes here, where should you go? I'd suggest you read the work of Professor Alison Pollock and Dr. Peter Roderick and Catherine Malloy on open democracy, and on social care particularly, the work of the APPG on limits to growth.